Hello and welcome everyone to today's session. We will get started in just a few moments. We want to give a chance for everyone who registered to enter the room before we begin. So once again, welcome to today's session just for situational awareness. All participants today are unable to unmute, unable to share video. So that's for your situational awareness. We will get started just in a few moments. Thank you. Welcome everyone today. As you join us, please feel free to let us know where you're joining from. I see many of you have already started engaging with the chat box, which we love. I'd love to see all the different places that people are joining from today. I like to always shout out that I'm in Phoenix, Arizona, though I always like to represent my home state of New Mexico. So thank you all for being here today and sharing this space with us. I love seeing the comments come through the chat, even though it is quite fast. I'm seeing Texas, Oklahoma, Massachusetts, Grand Rapids. Wonderful to have you all here with us. We're going to get started in just a moment. Great. Okay, the moment has came. We're going to go ahead and get started. Welcome everyone to our introduction to a new SAMHSA evidence-based resource guide on expanding access to and use of behavioral health services for people experiencing homelessness. Let's go ahead and turn it over. So welcome everyone. This is a SAMHSA, Opt Associates, and MHTTC hosted webinar on this guide. Thank you all for attending. Happy to have you here. A couple of housekeeping items. We've made every attempt to make today's presentation secure. If for any reason the presentation stops unexpectedly, we will follow up using your registered email, and we will keep going and get the presentation up and running as soon as we're able to. If for any reason you need tech help, if you can't hear or are having trouble, please write tech help into the chat, and I will be monitoring that and get you some assistance. At the end of today's webinar, we will ask you to complete a brief survey that just helps inform our future practice. So we'd really appreciate you to take a few moments to fill that out. Following the session, you'll also receive an email on how to access your certificate of completion. So all attendees who attend at least half of today will receive that. This event is closed captioned. We are on social media. You can follow us on Twitter and Facebook at MHTTC Network. One quick note is that this session is recorded and all of the materials will be posted to our website, mhttcnetwork.org, within 2 weeks, likely much sooner than that. A quick disclaimer that we are providing this webinar through funding from SAMHSA, and the opinions expressed here are the views of the individual speakers. Hello, everyone. I'm Felicia Benson, Project Coordinator for the MHTTC Network Coordinating Office. We are a network of 13 centers that provide training and technical assistance to the behavioral health workforce. 10 of these centers are regional, 2 are national population focus center, 1 specializes in Hispanic and Latino populations, the other in American Indian, Alaskan Native population. And then there's us, where I come from at the Network Coordinating Office to make that 13th center. I invite you to take a look at this map to see what regional center serves your state. It might be a little hard to see here on this screen, so please do visit our website, mhttcnetwork.org, to learn more and get connected to your center. In addition, this is the way that you can access all of our free, readily accessible resources and get connected to what upcoming learning opportunities, just like this one, that we may be providing in the next couple of days and weeks. So you can look out for our training and events calendar for that information. We want to recognize that our network and speakers strive to use affirming, respectful, and recovery-oriented language in all of our activities. These are our values and they are essential to our mission. So we invite you to do the same. Without further ado, I will now hand it over to Joseph Bullock from SAMHSA to start us off. Dr. Bullock received his doctorate from the Virginia Polytechnic Institute and State University. He is the former director for SAMHSA's Center for Substance Abuse Treatment and is currently a senior public health advisor with SAMHSA's Policy Laboratory. For this guide, Dr. Bullock served as a key liaison between the Policy Lab and the guide planning team, and has also been involved with many other EBRC products. Welcome.
Greetings and welcome. I would like to thank you all for attending today, and I'm pleased to kick off this webinar about an important new guide from our Evidence-Based Resource Center, expanding access to and use of behavioral health services for people experiencing homelessness. During the next hour, we'll learn about the process to develop the guide and the research included. We'll also hear from a member of the technical expert panel who provided guidance throughout the guide development process, and from 4 organizations featured as case studies, who will discuss how they implemented evidence-based practices for the specific populations they serve. Next slide. This guide was developed under the leadership of SAMHSA's National Mental Health and Substance Use Policy Laboratory, in collaboration with the Centers for Mental Health Services and Substance Abuse Treatment. The guide is one in a series of products that cover diverse topics in our Evidence-Based Resource Center. Over the past 3 years alone, SAMHSA has released nearly 30 evidence-based guides, practical guides, and advisories on a wide range of topics related to substance use and mental health. 3 of the most recently published guides focused on community engagement, community-level policies to prevent alcohol misuse, and adapting evidence-based practices for under-resourced populations. In 2023, we are working on 6 additional products. SAMHSA's vision and the underlying foundation for the guides is to reflect scientific rigor and make recommendations from the evidence base, provide expert consensus, be comprehensive and modular. Practitioners, administrators, other stakeholders will be able to use the guide in its entirety or just the sections relevant to their needs. Each chapter will stand on its own and be accessible to the field. We are pleased to announce this guide, expanding access to and use of behavioral health services for people experiencing homelessness, was posted to the SAMHSA store at www.samhsa.gov on January 17th, 2023. To speak more about this guide, I'd like to introduce Dr. Tamara Daly, Principal Associate at App Associates and the lead for this guide. Tamara?
Thank you, Joe. And I'm not seeing my video, but hopefully you all are seeing it. I want to welcome everybody to this webinar this afternoon. I saw a question in the chat about how many people are attending, and we're at about 860 folks. So welcome to all of you from all over the country. We're really excited to be here with you today. I want to start by just giving a little bit of context. I think many of you on the phone know that homelessness is one of the most visible manifestations of poverty in our country today, with more than 500,000 individuals experiencing homelessness on a single night, based on the most recent data from the U.S. Department of Housing and Urban Development. And as we're also well aware, the past 3 years have involved pretty significant economic instability and social disruption, in addition to major health challenges. All of this has exacerbated the homelessness crisis. The issue of homelessness and mental health in particular has become increasingly part of our daily news cycle, as you can see on the slide, the campaign platforms of our politicians, as well as just our conversations with colleagues, family, and friends. There are many clear and interrelated reasons why people experiencing homelessness show much higher rates of mental health conditions and substance use disorders than the general population. The list is long and includes multiple aspects of structural racism, trauma, lack of access to care, and other social determinants of health. Next slide. Over 20% of people experiencing homelessness have a serious mental illness, and an estimated 17 to 33% have received treatment for substance use. As many of you know, Housing First is an effective approach to reducing homelessness in the United States. It's based on the philosophy that housing is not conditional on sobriety or even engagement in treatment. Unfortunately, the supply of affordable housing is inadequate to meet the needs of those experiencing homelessness. And the nation's current shortage in housing has increased the number of people in unsheltered settings. Wait times for placement into permanent housing can be long, ranging from a few months to several years, and longer periods of homelessness are associated with lower rates of recovery and higher rates of psychiatric distress. So with the increase of people experiencing homelessness and shortage of housing options, that period prior to moving into stable housing is an important and critical window to offer services. Next slide. This guide focuses on programs and practices that may be useful during the period of homelessness prior to housing placement. The guide includes both the evidence supporting these interventions and specific strategies for providers, staff, and organizations to consider when implementing them. The purpose of the guide is to provide information and implementation guidance on 5 programs and practices. The guide also provides resources related to evaluation. The structure of the guide includes 5 chapters. Chapter 1 provides an overview of the challenge of homelessness, its definition and prevalence, the characteristics of people experiencing homelessness, and the behavioral health characteristics and service needs of this population. Chapter 2 describes the current evidence on 5 interventions to improve behavioral health outcomes for people experiencing sheltered or unsheltered homelessness. Chapter 3 provides practical information for providers, staff, and organizations to consider when implementing these and other interventions. Chapter 4 presents 4 case examples of organizations that implement the practices from chapters 2 and 3, and we'll be hearing from those 4 in just a few minutes. Chapter 5 provides guidance and resources for evaluating behavioral health interventions in the context of homelessness. In developing this guide, we started by working with our colleagues at SAMHSA and our subject matter expert, Dr. Avik Chatterjee, to identify the goals, audience, and intended population of the guide. To create our technical expert panel, we identified scholars and practitioners who had broad expertise. The panel included community providers, academicians, federal agency representatives, and administrators with clinical, personal, and applied experience. We conducted a systematic literature review of evidence-based interventions designed to improve behavioral health and related outcomes for individuals experiencing sheltered or unsheltered homelessness. We also identified the 4 case examples from different communities that have implemented these interventions. And finally, we collated guidance tools and resources to support implementation and evaluation. Now it's my pleasure to introduce Dr. Richard Cho, a technical expert panel member and a senior advisor for housing and services in the Office of the Secretary at the U.S. Department of Housing and Urban Development. Dr. Cho will discuss the role of the technical expert panel in the development of this guide.
Thank you, Dr. Daly, and also thank you to Dr. Bullock and the whole SAMHSA team who helped to develop this resource. I'm going to speak today about the role of the technical expert panel of which I was a part, but I want to take a quick moment just to say how I think incredibly useful and timely this evidence-based practice resource is going to be, particularly at a time when we have seen homelessness, particularly among those who are unsheltered, rising. And I want to take also a minute to just remind folks, if you haven't seen already, HUD made a major announcement today where we have awarded $315 million to 46 communities to specifically provide housing and supportive services to people who are in unsheltered settings and people who are experiencing homelessness in rural communities. Actually, we expect to make in a few weeks a second set of awards to additional communities, as well as allocate housing vouchers to awarded communities. And I actually see a number of the folks who are participating in this webinar today. You are part of grantee community, so congratulations if your community is getting an award. But again, the key to solving homelessness is the combination of housing and supportive services, including the kind of recovery supports and other behavioral health services that are discussed in this resource guide. So I'm incredibly proud to be part of this technical expert panel. We were a panel of folks who were really intended to help this team identify the relevant research and data that's most relevant to this topic, to develop a consensus perspective on what are the evidence-based practices that we want to feature, and also to identify what we think the field needs to know in order to implement these practices effectively, as well as to find examples in the field to be able to highlight. On the next slide, you will be able to see, next slide, please. Great. You'll see the set of colleagues who participated along with me, and you'll see it really represents a whole range of experts, people who work in housing like myself, researchers who work in both public health, addiction medicine, in behavioral health, as well as other policy experts, including people who actually are working in the field, and a number of federal agency officials. We worked really over the last year to help review, advise, and provide feedback on this resource guide. We met first back in January, almost a year ago, a little over a year ago, for 3 hours to just provide kind of framing and scope for this guide. We then met in April of 2022, after we've had a chance to review the initial chapters, and we went chapter by chapter, really helping to ensure that we are providing the most relevant information to what's happening related to people experiencing homelessness, the available literature, the latest data and research that's out there, and then also to advise on identifying case studies of organizations in the field, many of you who may be even on this webinar, that should be featured as kind of examples of how they've implemented these interventions. And we also provided guidance for how to evaluate and measure the success of these interventions to the field. We actually highlighted and focused on a number of things where we wanted to make sure we place some emphasis. Number one, as Dr. Daly and others have already mentioned, we wanted to ensure that this resource guide was rooted in the evidence-based proven housing first approach. As Dr. Daly noted, you cannot end homelessness without housing. Housing is what ends homelessness, is what people need. But it's not the only thing. People also need wraparound supportive services. They need behavioral health supports. It's just that the housing first approach means that we need housing first and as the foundation to be able to provide those additional behavioral health services and other supportive services that people need. So that was one piece of feedback. The second was, we know many of your communities are also struggling with the opioid epidemic and the opioid crisis that is intersecting with homelessness. And that we wanted to be able to make sure that we talked about the importance of medication-assisted treatment as one of the additional things that needs to be layered on in terms, in addition to affordable housing and supportive services, is people also need a medication-assisted treatment and Medicaid for opioid use disorders, and the role that that can play in providing impact on housing stability. Third, we provided some suggestions on what literature should be looked at and outcomes of focus emphasizing the engagement of services, right? It's one thing to provide effective behavioral health treatment, but what many people experiencing homelessness struggle with is even how to connect to those services, how to engage, and how to overcome their ambivalence. So there's a lot of emphasis placed on harm reduction and on client engagement and relationship building in the kind of interventions mentioned. And again, we again emphasize the importance of building trust with community members and listening to the people who know how to solve homelessness the most, which are the people who are living the experience of homelessness or who have recently become homeless. They are the ones who are closest to their problems. They're the ones who are closest to the solutions, and really to emphasize listening to people who have lived experience. So with that, I might have taken a little more time than I was supposed to, but I want to just emphasize how much I appreciated being part of this technical expert panel and to be part of the team that helped to produce this incredible resources at a time when HUD is providing grant dollars as vouchers to communities to help solve the homelessness encampment problem, as well as unsheltered homelessness. We hope you will use this resource guide and help break down the silos at the local level between behavioral health and supportive services and housing in the same way that we are trying to do that at the federal level. So thank you so much. And I will turn this back to, I believe, Felicia or Tamara.
Thank you so much, Richard. I really appreciate those comments, and it's terrific to hear about the recent HUD Awards. Very exciting. So I'm going to spend just a few minutes talking through the process of identifying and reviewing research on the interventions that we included in this guide. We can go to the next slide. We began by looking at systematic reviews to identify existing studies that focus on individuals experiencing homelessness and behavioral health topics. We shared a long list of potential interventions with SAMHSA and our experts, who helped narrow these down to 5 approaches for inclusion. We then screened 1,057 abstracts to identify articles that met our criteria. We included only articles published since 2002 and written in English, though they could be in other countries. A key was that the approach must have been used with people experiencing homelessness before they were housed, since that was the focus of the guide. Lastly, we extracted information and synthesized the findings, which is what appears in Chapter 2 of the guide. Next slide, please. And now I'll just briefly talk about the 5 interventions before I turn it over to our case studies. So the interventions covered in this guide are motivational interviewing, a collaborative approach that uses a goal-oriented style of communication, which allows the client to direct the change rather than telling the client what they need to do. Motivational interviewing is typically provided in conjunction with other service modalities and is a short-term intervention. Another of our interventions was intensive case management, in which providers can broker services and support clients in identifying and accessing supports by making linkages and warm handoffs to mental health and substance use disorder treatment, housing, and wraparound services. Medication for opioid use disorder, which Dr. Cho mentioned, commonly known as MOUD, is the use of a medication that targets the brain and is often used in combination with counseling and behavioral therapies to provide a whole person approach to the treatment of opioid use disorders. Community reinforcement approach, or CRA, is an approach that was developed with adults and adapted for use with youth experiencing homelessness to encourage involvement in non-substance related social activities, reduce substance use, and improve mental health and well-being. CRA can also accompany other modalities. And last, but certainly not least, peer support services encompass a range of activities and interactions between people who share similar experiences of being diagnosed with mental health conditions, substance use disorders, or both. In the context of this guide, peers are individuals who have both experience with mental health disorders and or substance use disorders and or have previously experienced homelessness. Individuals who provide peer support may be referred to as peer navigators, peer support workers, peer specialists, peer recovery coaches, peer recovery specialists, trained peers, peer supports, or just simply peers. As I mentioned earlier, one of the best studied models of serving individuals experiencing homelessness is Housing First. So in addition, many of you are likely familiar with the use of assertive community treatment, or ACT, for individuals with serious mental illness. This guide provides some basic information about both these models and refers the reader to more comprehensive resources that have been developed by SAMHSA as well as prominent national organizations. And next slide. We'll now hear from 4 organizations that have implemented one or more of these approaches and the lessons they have learned through their experiences. Next slide. Our first example comes to us from the Colorado Coalition for the Homeless, based in Denver, Colorado, and presented by Kevin Raleigh. Kevin is entering his 18th year at CCH and supervises 4 frontline programs: the Denver Street Outreach Coalition, Strategic Outreach to Large Encampments, Family Outreach, and Native American Services, in addition to a fledgling street medicine pilot program. Kevin is going to talk with us about his work through the Native American Services program in particular.
Okay, I'm on and trying to do the hardest thing in the world, which is talk for only 6 minutes. Welcome, everybody. So Colorado Coalition for the Homeless is a very large nonprofit of about 750 staff that provides housing, integrated healthcare, and supportive services to individuals and families surviving and recovering from homelessness, mostly in the Denver metro region. The occasion for my participation today is specifically our small but very mighty Native American Services program. For over 20 years, Native American Services at CCH has created the space and opportunity for cultural practice, for community engagement and social support for Indigenous individuals and families who are surviving, who are at risk of, and who have also managed to exit the profoundly diminishing experience of homelessness. And the approach I'm focusing on today is what can happen when you honor and make a virtue of weaving vibrant cultural and community programming with relational, intensive healthcare and housing focused service navigation and case management. So why does the Coalition for the Homeless have a Native American Services program? Of course, we have to talk about the disproportionality of early deficits, homelessness rates, and health outcomes for American Indians and Alaska Natives. Not in gross totals of individuals, but as a percentage, Indigenous people are the most overrepresented group experiencing homelessness in Denver at a rate 7 times higher than their demographic representation in the general population. But the true origin of this program at CCH is that the unhoused Indigenous community initially gave CCH this programming model, not the other way around. Our creation story is that over 20 years ago, a group of unhoused Native folks connected to CCH services wanted to start hosting talking circles. And all they asked for from CCH was the use of a kitchen and a conference room. So talking circles, by the way, are communal rituals in a space made sacred where participants from this community can speak confidentially about their lives. So eventually CCH developed funding and staffing support around talking circles, but it has been an essential part of our program and its DNA that our participants started this program and continued to shape its evolution and growth, which leads me to the first takeaway that I want to leave, which is this approach cannot work without being profoundly attuned and responsive to the community you serve. This looks different in Denver than it does in Seattle or Phoenix or Minneapolis, or a city near the Pueblos of New Mexico. Denver is a large city in the middle of a circle of Southwest, Plains, and mountain tribal lands, and our Indigenous population is a really diverse one. So the history and complexity of Denver's Indigenous community absolutely defines our programming. Effective intensive case management, it requires allocating the time necessary for building genuinely and organically formed trusting relationships. And while there are obviously universal applications of this idea across demographics, it happily coincides with cultural values and social expectations that are very prominent across Indigenous groups and American Indian and Alaska Native tribes and nations. In this program, we believe that culture and community are two of the least understood and most undervalued components of behavioral change and recovery. So I just want to look back the previous year. With only 2 staff in this program in 2022, Native American Services facilitated over 100 community events and cultural, seasonal, and memorial programming with 94 unduplicated participants. So this includes formal talking circles, an informal circle clubhouse, hiking trips and social activities, seasonal events like the Three Sisters traditional food celebration, Denver March powwow, and also ceremonial support for members who have walked on or passed away. Additionally, our Native American Services staff facilitate Red Road to Wellbriety recovery groups, which is a 12-step model overwritten with Indigenous traditions, spirituality, metaphor, and stories. Last year in 2022, Native American Services, our outreach case manager, had 297 service engagements with 102 unduplicated people and helped house 39. Mostly they were individuals who were experiencing chronic homelessness. The case manager, the outreach case manager, takes referrals from the larger community, participates and holds office hours before and after our programs, and also engages new people through street outreach. There's designed and intentional fluidity between the roles. So The outreach case manager assists with programming and events, and the coordinator also brings culture and community programming outside of our building to camps and to parks and to other spaces. Which leads to the second takeaway, which I want to share, which is we have found that melding intensive case management with our traditional programming has been an autocatalytic process. Overall, each side strengthens the other. The combination enriches and deepens engagement. And it's not, so I want to, one quick caveat, it's not frictionless or linear. Doing this creates complications that don't exist in other programs, but the net result has been absolutely worth it. I want to point out that in Native American services, the term of we call our clients unhoused relatives, and the people who participate in our programming are members. And I want to just give kind of one example of this, what it looks like in action. Anywhere else at the coalition, a case manager is finally helping somebody move into housing. Of course, we help them with the basic material needs for that transition. You get somebody a mattress and some furniture and some starter items and kitchen stuff, and of course, toilet paper. And the way that this looks different with the Native American Services Program is that we do all of those things. Toilet paper to our members in Native American Services, the TP actually stands for treaty paper. That's one important difference. But we go an additional step. And so we also give welcome baskets with traditional foods and sweetgrass, sage, other culturally relevant objects. And the coordinator offers to smudge a new space or to acknowledge that important transition with prayer or sacred song. Last thing I want to leave you with is the takeaway that small is okay if the idea is well conceived and meets a need, and if you're skillful at leveraging partners. So Native American Services is this, now we have 3 FTE. It's this very small program in a very large organization, but we have enormous reach into our organization and into the service provider landscape in Denver. And I love this. There are members of Native American Services who, rather than thinking of our program as a very small part of the Coalition for the Homeless, think of the Coalition for the Homeless as an extension of Native American Services, which I love that is the way that we've been able to provide access to the community. Mention one success in the past year in Denver, the Native community advocated for and helped build a Native inclusive safe outdoor space. And our very small program was perfectly positioned and ultimately ended up being the largest source of referrals to that opportunity. So, quick recap: attunement and responsiveness to the community is foundational. Weaving culture, community, and services can be an amplifier of your intended outcomes, and small still can be powerful. It shouldn't discourage you. And I think that's me. Thank you, everybody.
Thank you so much, Kevin. I am really moved by a lot of the things that you expanded on that go well beyond what we were able to include in the guide. So I really do appreciate you bringing those to the webinar today. Let's go ahead and move to our next case study. Next slide, please. Next, we are going to be hearing from Ann Ryan, who is the Program Director of Resources for Human Development's Fast Connection Targeted Case Management Unit in Philadelphia, Pennsylvania. RHD works in collaboration with the City of Philadelphia Department of Behavioral Health and Intellectual Disabilities, Housing and Homeless Services. Ann's primary focus is to establish collaboration with inter and intra-agencies to provide housing supportive services. Ann has expanded the program from a shelter-based program serving 30 individuals diagnosed with mental illness to a unit that serves upward of 500 individuals with mental illness experiencing homelessness in a fee-for-service program. Ann, I'm going to pass over to you now.
Hi, good afternoon, everyone. Thank you, Tamara, for that introduction. Fast Connections, in partnership with the City of Philadelphia, we work out of many of the shelters in the City of Philadelphia, providing targeted case management. We work with folks from shelter to self-sufficiency through strength-based case management. And that's one of the key things that our team does with individuals is provide that strength-based case management. We work with families. The identified participant in our program is usually the parent, but at times we provide assistance with linking the children to services, because if the children are not okay, usually the parents are not okay. One of the key things about our program is we're able to work with folks outside the shelter system. So we'll start working with them in the shelter system and continue our work outside the shelter system to integrate folks into the community and stabilize them there to reduce recidivism. One of the key important factors that we do inside the shelters by starting to work with individuals while they're still in shelter is we develop a rapport with the shelter staff. We have our team, we have a select individual at designated shelters, and that's their assigned shelter. So they'll work with individuals and families in those shelters, develop a rapport with the shelter staff in order to provide service and wrap the service around the individuals receiving the service. The criteria for our program is that you have to have a mental health diagnosis, you have to be homeless, and you have to be at least 18 years old and agree to the service. Sometimes one of the challenges that we face is individuals, particularly with families, we find this, that they're hesitant to admit to a mental health diagnosis. So oftentimes we'll use just engaging strategies with individuals to help them overcome their fear of divulging a mental illness in order to meet the qualifications for the program. We use motivational interviewing skills, and we go from a strength-based approach. We find that building a rapport and building trust at times can be challenging, and we do this with the shelter staff as well as the individual to provide more holistic treatment. We tailor our approach to each individual because no two people are the same. They're all experiencing housing insecurity, but we have to tailor our approach according to where that person's at, and we work from a harm reductions model. Once folks are out of the shelter, we'll continue to work with them for up to 2 years, and then as they no longer need our services, we will back ourselves off of services, making sure that individuals have the resources needed in order to sustain independence outside of the shelter system. And Tamara, I will pass it back to Tamara.
Thanks, Anne. Really appreciate that overview of work in Philadelphia.
You're welcome.
Next, we're going to hear from Ashley Blum, who's worked at, we can go to the next slide, there we go, who has worked at Park Center in Nashville, Tennessee for 16 years and has held many roles, including being a care manager, SOAR coordinator, the director of residential services, director of homeless outreach services, and now the director of philanthropy. She has worked closely with the peer recovery specialists and street medicine programs and has been an integral part of growing the outreach team from 3 to 25 staff. Ashley has also been the project director on 2 SAMHSA grants to serve people experiencing homelessness and mental health and substance use disorders while incorporating peer and street medicine work. Over to you, Ashley.
Thank you, Tamara. So I'm just going to start by telling you a little bit about our organization. Park Center is a nonprofit mental health organization that supports people experiencing mental health and substance use disorders and homelessness live and work in their communities. We're not a clinical model, so we work in a holistic manner while offering permanent supportive housing, supported employment with using the individual placement and support model, IPS. We have addiction recovery. We have a day program and homeless outreach services. We meet people where they are and work alongside them to ensure their basic needs are met and that they are connected to the resources that they need to support their own recovery. We value hiring people with lived experience of mental health and substance use disorders and homelessness, as their approach brings such an important perspective. Today, I'm going to talk specifically about the work we've been doing on the homeless outreach program through a 25-person team funded by city, state, and SAMHSA grants. The team has faced some tremendous challenges recently in Nashville that have impacted our ability to work with people the way that they deserve. Nashville lacks deeply affordable housing, and as Tamara and a few other people have stated, it's a major issue across the country. And although we are seeing much needed support and much needed steps coming our way to end homelessness in our city, Nashville has also drastically been growing, and we have had to push people out of our city further from the resources. Over the last few years, some of the landlords and properties that were our affordable housing properties for folks have been going away. Developers are coming in, tearing them down, and building more high rises and things like that have been pushing the folks that we serve into homelessness and outside of Davidson County. So if people are getting further from resources with nearly no transportation and from those smaller towns to Nashville, people are not getting the care that they need for their mental and physical wellness. So we've also faced a lot of camp closures in Nashville, which has also been really hard and been getting people further from care. This develops a lack of trust for the systems when then that impacts our ability to stay engaged with the people that need our continued services. So the steps we've taken to fill the gaps with these marginalized communities is really developing street medicine teams through a partnership with a clinic here in Nashville where we take care to people. We partner with our street outreach team and the doctors, and we go out and we wrap resources around folks. So we have our peers and our street outreach workers and the doctors. We take these doctors under bridges and encampments and into safe spaces that folks choose for us to meet them in. So we do not require that people that we serve come to us, and I think that that's a really big deal. On our outreach team, we definitely take the services to people. That's a barrier, that is one more barrier that limits people's ability to get the care they need. So with incorporating people with lived experience to work alongside those doctors and community providers, we support them we support those peers with getting their certified peer recovery specialist certification, like Tamara was saying. But that is a completely different perspective of work. And what we feel at Park Center is we don't have titles that are peer recovery specialist or, well, at least on the outreach team, I think we have a few of them sprinkled throughout the organization. But on the outreach team, we have senior managers, team leads, direct care staff, all in all of those levels, we have peers. It is important because peers bring this new perspective. And this approach is essential to meeting the needs of the people we're serving. So with creating this team, we have a team of street outreach workers that help people get document ready for housing placements. We have housing navigators where they work alongside our property engagement coordinator to secure safe and affordable housing. And we have SOAR coordinators to support people obtaining disability benefits through the Social Security Administration. So some of the lessons that we've learned are that if you bring peers in, they will bring a new perspective to the work. They will help you see things that they've experienced in another light. So if you think about someone that has lived a similar path to someone, they're going to bring what worked for them to the work. Because we have to take into consideration that all people have different needs and the environment impacts people and their recovery differently. So just some examples of things that we've learned with bringing peers in the mix is that, so think about if someone's sleeping outdoors and prescribed insulin. Okay, where's that person going to keep that insulin cool? Or if they have a bubble pack, right, with a cardboard on the back and they live outdoors, that's going to get wet and those meds are going to get ruined. So we as communities, to be able to meet people's needs, we have to be creative and think past what we've always done. And that's one thing that Park Center does really well, is that we create these paths so that we can, understand and in this path of having peers, and so that we can understand what it's really like. Because hearing from peers and helping us kind of think outside of what we've normally done is such a true gift. So thank you for your time today. I appreciate y'all having me.
Thanks so much, Ashley. We are going to move to our last case study presentation. Next slide, please. Jennifer Smith-Rainey is the program manager of the substance use and co-occurring program at Horizon Behavioral Health, which is in Virginia, and I think she will tell us a little bit more about that. Jennifer has been a licensed professional for 25 years and has worked with a variety of populations, including adults with serious mental illness and adolescents with co-occurring mental health and substance use disorders. She's also worked on 2 SAMHSA grants as clinical supervisor and principal investigator. Jennifer?
Thank you, Tamara. It's a pleasure to be here. I am from Central Virginia, and I see that we have many Virginians on our webinar today, so it's exciting. I'm with Horizon Behavioral Health, and we are a community service board. So we are the single point of entry for all publicly funded mental health, substance use, and intellectual disability services within our catchment area. And in Virginia, we are one of 40 community service boards. Annually, we serve over 15,000 individuals and families in Horizon's area through a continuum of care that includes prevention, treatment, outpatient services, case management, emergency services, crisis stabilization, and women's residential substance use treatment. We also have medication management services, including psychiatric services, as well as medication-assisted treatment. And I'm here today to talk about a program that we implemented in 2017 as part of federal grant funding. We received funding to develop and implement a homeless wraparound outreach program for homeless youth and young adults living in our catchment area. As part of our wraparound program, we had a multidisciplinary team that included a housing specialist, an employment specialist, 2 outpatient counselors, 2 case managers, and 1 peer recovery specialist. Our goal with this project was to link homeless youth and young adults to permanent, stable housing. And we very much emphasize the housing first model that Tamara and Dr. Cho talked about. We recognized that coupled with housing first was the need to provide substance use and mental health treatment and recovery supports. The treatment model that we chose, and we looked at the literature, and we saw that there was a model that Tamara mentioned called community reinforcement approach that had been researched and shown to be effective in working with the homeless population. In addition, there is an adolescent and young adult adaptation of the model called adolescent community reinforcement approach. And in short, what this evidence-based model allows us to do with our clients is to work with them collaboratively, respectfully, engaging and understanding their culture through a cultural humility approach, and helping them identify reinforcers for sobriety. The goal of this treatment model is to replace substance-using behavior and other problematic behaviors with healthy and positive behaviors and activities called prosocial behaviors that are more rewarding than substance use and other problematic behaviors. As we identify prosocial activities, we're also teaching and modeling skills for our clients. And these skills include positive communication skills, problem-solving skills, other skills. Some of our clients needed anger management strategies. Some may need drug refusal skills, certainly job-seeking skills. But this evidence-based model focuses very heavily on increasing pro-social behaviors coupled with skills training. Now, some of the challenges that we encountered in implementing this program, recently we did some quantitative analysis, and we did something called a cluster analysis. So we were able to analyze which clusters of homeless youth performed well with this wraparound approach and which had some problems. So one of the challenges was our cluster of clients with opioid use disorders and stimulant use disorders. Very similar to what was already previously mentioned on the webinar by Dr. Cho. So that was a challenge for us. They did not tend to engage and retain in treatment compared to their counterparts. I'll talk about ways that we address those challenges in just a minute. Other challenges in our catchment area, we are a multi-city, multi-county catchment area. So we have a combination of urban and rural localities, and transportation was a consistent barrier with this program. Our rural localities do not have a public transportation system. And even in our urban localities with public transportation, that was not always reliable or effective for our clients. We also had some just tangible challenges in working with our clients. Many of them lacked client IDs that they needed to be able to get a job, to get a driver's license, to get housing. Temporary storage was another issue in terms of storing their belongings as we were working with them to house them. Some approaches to address these challenges included targeted peer support, and that was a key takeaway and lesson learned for us. One of the speakers talked about peer support. We found that our peers engaging early in treatment with our clients was helpful not only to link and engage them, but to retain and to develop those relationships. So we developed a model where our clients would meet the peer as soon as they came in from the intake. Our admissions department would call our peers and they would go and make that warm handoff. And that really assisted us with engagement. Other takeaways included linkages to the medication-assisted treatment for our clients with opioid use disorder, and developing a continuum of recovery supports that's very individualized. Evidence-based treatments are often seen as manualized. However, this evidence-based treatment is intended to be flexible and adaptable. So we developed a plan of care collaboratively with our clients where we would individualize their needs. And then lastly, having a drop-in and flexible scheduling for our clients was key takeaways. So Tamara, I'm going to turn it back over to you.
Thank you so much, Jennifer, and thank you to all our case study presenters. These 4 case studies really provide an excellent snapshot of specific instances of implementation, and I definitely encourage you to contact the presenters directly if you have questions. As Felicia mentioned, we'll be sending out the slides in about a week, and all that contact information is on there. I'd like to go to the next slide, please. So just to wrap up the rest of the guide, you've heard about really an overview of what is contained in the first 2 chapters, what our case study presentations kind of illustrated chapter 4, and I wanted to just give a brief overview of chapter 3. It includes sections that cover implementation considerations and strategies for organizations, for clinicians, and other staff members, as well as implementation resources for each of the 5 interventions that you've heard described earlier. There are links to nearly 50 organizations, guides and resources, and other types of materials that you may be wanting to access. On the right side of the slide, we've highlighted just a few of these, some of which are from SAMHSA. And again, you'll be able to click these links directly from the slides that you'll receive in a week. Next slide, please. Lastly, I wanted to just spend a minute talking about our final chapter of the guide, which is about resources for evaluation. So program evaluation can occur at different levels of depth and rigor and through multiple approaches, as well as for different purposes. Jennifer gave a good example of evaluation of the program that she has been working with. Evaluation can answer important questions about which aspects of a program are working and those that might require modifications. Evaluation can also help identify whether programs are being implemented as intended and show how individuals are impacted by the intervention. This chapter of the guide provides an overview of different types of evaluation approaches that behavioral health and housing providers might want to use to assess implementation of behavioral health interventions. This chapter also provides an overview of continuous quality improvement, a process for assessing program or practice implementation and short-term outcomes. With that, I'd like to turn it back to Joseph to wrap up with us today. And thank you all very much for your time and your attention and all of the great messages in the chat.
Thank you. I want to thank everyone today for joining us for today's webinar on expanding access to and use of behavioral health services for people experiencing homelessness. Guide. We heard from Dr. Tamara Daly on the process for developing the guide and supporting research. Dr. Cho provided some information on the role of technical experts, as well as the major announcement of additional resources made available today through HUD. And lastly, we heard from the 4 organizations featured as case studies in the guide. And I want to salute all of the boots on the ground personnel carrying out the great work of engaging with this population and the daily challenges they face to gain housing and other services. If you would like to learn more about the policies discussed in this guide, you can download it at the samhsa.gov website. It's located in the SAMHSA store. Also, you can email the SAMHSA's EBRC team to address. We'll have that address in our resources. Thank you again for joining us today for the exciting release of this guide. And now I'm going to turn it back over to Felicia, who will tell you how you can access your certificate of completion for attending today's webinar.
Thank you, Joseph. So I'm just going to do a quick wrap up and next steps. Thank you all to the amazing speakers today and the developers of the guide. For those next steps, we have a very brief survey that should take no more than 5 minutes. I've put the link into the chat. We really would appreciate your feedback, whether it's positive, negative, anything you'd like to share so that we can plan better sessions for you in the future. Within a week, be on the lookout for an email that's going to have all of the material, the video recording slides. It's going to have the links that you saw today and where you can access those. Apart from that, really just once again, a big thank you, virtual round of applause to all the presenters, all the people that made this possible, SAMHSA, APT Associates, the EBRC webinar and guide series. So thank you all for sharing this space with us. And thank you to all of you who made this a shared space for learning today. So thank you again. Thank you all.